This conference will now be recorded.
Hi, everyone. Okay, so today we're talking about bipolar disorder and related disorders. Okay, so the DSM-5 is the textbook for all disorders, whether it's thought disorders, mood disorders, or personality disorders. Also mental health issues related to medical conditions. So today we're going to talk about bipolar disorder, which is classified as a mood disorder. But in the DSM-5 that was recently revised, the bipolar related disorders are considered the bridge between schizophrenia and depression. So schizophrenia, spectrum disorders, and depressive disorders. They're considered the bridge that connects the two, and we'll talk about why. So bipolar 1 and bipolar 2, we've heard a lot about bipolar 2, probably more so in the last 8 to 10 years or so, because they broke down the cluster of symptoms and made it a little more specific. So bipolar 1 disorder, it's what you would classically call manic depression in the old term and the new term. It's just called bipolar now. It's required that there be at least one manic episode, full manic episode, for this diagnosis to be given. So if somebody is depressed and agitated or irritable, you cannot assume that they have bipolar 1. So bipolar 1 disorder, you definitely notice mood disturbance. Okay, there's very typically cheerfulness, euphoria, but then you may have the add-on of irritability. And irritability is one of the most common symptoms of the depressive side that you're going to find. Irritability is one of the most common symptoms of depression. So often people look for sadness, hopelessness. Irritability is usually going to come first. So increased activity. So meaningful activity and almost just busyness, you're going to notice. The more manic, the higher level mania that develops, the more disorganized a person's going to get. So meaningful activity is going to get disrupted. And that's one really big thing to remember. In order for bipolar 1 to be diagnosed, the symptoms that we just talked about, the mood disturbance, the cheerfulness or irritability, the euphoria, the increased activities, the noticeable changes in behavior have to be present for at least 1 week consistently. And often they look to 2. Okay. So if it's up and down over a period of a week, it's not going to meet the standard. It has to be consistent, okay, for that diagnosis to be given. So symptoms you're going to find, you need at least 3 if there's no evidence of irritability. You need 4 of these if there's evidence of irritability. So the first one would be inflated self-esteem, grandiosity. You have to be careful because people with personality disorders that mimic this, you need to look further. Okay. Decreased need for sleep. You also need to look beyond that and look at, is there medications causing disruption? Is there personal trauma or anxiety related to situations or environment? So these are not things that are just readily identifiable. You have to look at the environment in which the person is in as well. More talkative than usual or pressured speech. And pressured speech simply means the person feels pressured to keep talking. It's not necessarily specific content, which some people may assume. Okay, pressured speech is just that internally I feel pressure to keep talking and make, verbalize. So that's one thing to keep in mind. The pressured speech is, the volume is almost always louder, okay, just because of the nature of that, okay. So the person will probably be difficult to interrupt, and they call that tangential speech. And tangential just means ongoing, connected, ongoing, connected, ongoing, connected. Even if the subject matter changes, it's going to be like a ramble, okay. So they're going to be difficult to interrupt. And we'll talk a little bit about how you can, get in there and disrupt that a little bit, but it's not easy. So there's flight of ideas, and what happens is that flight of ideas, a person subjectively can almost picture their thoughts racing. So if you think of like a cartoon where words come out of somewhere and you see the words, picture being able to see that in your mind and the words just swimming and swimming and swimming and swimming, and not being able to separate one thought from the next. So the person may very well recognize that what they're talking about here and here is not related, but they connected them, which is frustrating. So sometimes where staff gets frustrated is they're like, whoa, 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 we were talking about this. And it's not helpful because the person doesn't see that it needs to be disconnected at the time. Does that make sense? So keep that in mind. It can be frustrating both for the client and for the staff. So distractibility. Distractibility is different than agitation. So one thing to keep in mind is it distractibility or is it anxiety driven? Distractibility simply means difficulty holding attention, okay? If it's agitation, it's a pressure either to move or to look elsewhere or to avoid eye contact or to problem solve while I'm doing something else. And so pay attention to what's going on at the time. Distractibility just simply means I cannot hold my attention to task very easily. It is fairly unemotional, okay? So then the person is usually going to get excessively involved in activities with a high potential for what they consider painful consequences. So overspending is going to give you a huge credit card bill that you can't pay. Or fast driving is going to possibly give you a traffic ticket or a trip to jail. Sexual indiscretion might give you an STD or a pregnancy. Things like this. So the painful consequence is what is important. Okay. It's not that they wash the dishes all day. Okay. It's the painful consequence that's attached with the behavior. So with bipolar 1 disorder, the symptoms are severe enough to impair social and occupational roles. Absolutely non-negotiable. They're going to be disrupted. And the other thing too is that a third piece of that is that in bipolar 1, the symptoms are severe enough to warrant hospitalization. And we'll talk about the difference with bipolar 2 because they look very similar, okay? But the level totally changes the outcome. Totally changes the outcome. So if you think about impairment in social functioning, that can be everything from how do I interact with the person I'm paying for my gas with to how do I handle my spouse or my children. So social means interaction with another person, okay? Occupational is not just my engagement with my coworkers related to the role I'm in, but my attention to task and my completion of activities. So that's why the two are separated, the social and the occupational. They bleed into each other, but both are diagnostic considerations that's necessary for the diagnosis. Hospitalization, you're not going to see hospitalization traditionally with bipolar 2. You're just not, because the symptoms don't get to that level of disruption, okay? Which often can get to the level of dangerousness. Okay. Bipolar 1, people often ask, what's the risk of suicide, what the anxiety associated with it? Most commonly, and I forgot to write down the percentage, but people with bipolar 1 who commit suicide often do so accidentally. And it's through some type of impulsive activity or high-risk behavior that people think they killed themselves purposely. Okay. So that's one thing to keep in mind as well. And that is very similar to borderline personality disorder. If someone with borderline personality disorder completes suicide, often it's without the full intent of completing suicide, but it's for different reasons. Okay. Okay, so looking at bipolar 2, where bipolar 1 requires at least one manic episode, bipolar 2 requires one episode of major depressive episode, one episode of major depression. So it's the opposite end of the spectrum, okay? They also need to have at least one hypomanic episode. And what it is it's increased activity, intent, and energy, but not to the level of severe dysfunction or impairment of social and occupational roles. And we'll talk a little bit more about that. So that's kind of just the umbrella. So the same criteria goes with bipolar 1 as bipolar 2. You need 3 criteria, or you need 4 if there's irritability. And I'm going to go back just a second to the fact that irritability is the most common symptom of depression early on. It's not hopelessness, it's not sadness, it's irritability. So again, you're looking at inflated self-esteem or grandiosity. You're looking at decreased need for sleep. You're looking at the person being more talkative or pressured. But you're going to note if you would put someone with bipolar 1 disorder here and bipolar 2 disorder next to them, you'll see the symptoms that are similar, but they're at a much different level. And you're gonna see that, okay? Someone who has pressured speech with bipolar 2 disorder, which is primarily depressed a lot of the time, will be pressured, and often break down and cry. Someone with bipolar 1 will be pressured, and it might escalate into manic behavior rather than speech. So pay attention. The distractibility, the increase in goal-directed activity. Often in bipolar 2, the goal-directed activity is quite functional. They're very productive at work. Their house is spotless. They tend to overcare for people or pets. It's very conscientious. So many people think it's just conscientiousness. Employers love it. Organized, task-oriented, goal-oriented, not realizing that the person is doing it because they're pressured to do so, not because they're looking for the outcome or they're looking for the raise or they're looking for the supervisor approval. That's not what it's about, okay? That's more personality stuff. So there's a pressure to perform in meaningful activity, and often it looks like meaningful activity. There are still examples of behaviors that have somewhat painful consequences. In bipolar 2, spending is very common because it supports self-esteem deficits. And if I don't feel good about myself, then the clothes and the shoes and the hair and the nails, things like that. If I get depressed, I'm going to start feeling bad about myself. So you're going to see that kind of stuff in a different light than you might with bipolar 1. The one thing to really keep in mind is the depressive side of bipolar 2, because often that's prominent. And the irritability that comes with depression may be more prominent than in bipolar 1. So, questions so far? Okay. So you're looking at excessive involvement in activities with painful consequences, but usually not to the level of risk or the level of dysfunction as bipolar 1. So many people think bipolar 1 is just less of bipolar, is just more of bipolar 2, but they do look different. So you need to pay attention to that. There's commonalities, but the big thing is that the marked impairment in social relationships, the marked impairment in occupational. And by occupational, I don't just mean job. Occupation, like if you think of occupational therapy, it's life skills. It's independent living skills. It's problem solving. It's scheduling. It's planning. It's budgeting. You know, occupation is daily living. It doesn't mean I go to a job from this hour to this hour. So if you can, every time you hear the word occupational, if you can think of that rather than just where do you work, it's going to really open up a lot more areas that you might see things and you might notice things. Especially within the houses, you know, look at the environment and look how they're functioning within the environment, because life skills and daily living are going to be affected either way. But often, if it's a full manic episode, there's going to be some significant intervention that's necessary, hospitalization or, you know, some kind of limit setting, something like that, medications. So looking at bipolar 1 and bipolar 2, if there are any psychotic symptoms noted, auditory hallucinations, olfactory hallucinations we talked about, those are hallucinations of smell, visual hallucinations, paranoia, paranoid delusions, delusions of persecution, bipolar 2 is off the table, and you're automatically going to be back at bipolar 1. Bipolar 2 has no indications for psychosis, none. Okay. So by definition, if someone is psychotic, the episode that they're in is considered manic for whatever reason. So the psychosis is only by definition in a manic episode, not in a hypomanic episode. And that's outlined much more clearly in the DSM-5, which some people find really helpful. Other people think it's too picky, you know, but I think it makes a big difference because it makes a difference in the treatment. It makes a difference really in the stigma. If you think about the stigma, if you say somebody has bipolar disorder and they're manic, you know, all of a sudden red lights go on. You know, if they're hypomanic and depressed, you're not going to get that level of, you know, especially from caregivers and often from family. You'll see the same thing. They're manic. And right away people think dangerous because they automatically go to impulsive. Well, impulsive isn't the primary symptom. The grandiosity is, the higher risk behaviors like spending, sexual indiscretion, things like that. So you're not going to see what many people assume to be primary symptoms like dangerousness or acting out or assaultiveness or aggression, okay? Those often are a result of different factors coming in. So psychotic symptoms, the episode is automatically, by definition, manic, not hypomanic. And hypo just means less than, really, as far as the mania definitions go. If you think of hypothyroid versus hyperthyroid, same thing. So with medications, mood stabilizers are very common. Lamotrigine or Lamictal is extremely commonly used. Often it is paired with Abilify, because Abilify does what they call augmenting the lamotrigine, and it gives it a boost. So if someone is taking lamotrigine and they're responding pretty well, and then things kind of start sliding a little bit, they might add a small dose of Abilify, and it might boost the lamotrigine. It's very commonly used, the two together. The other thing about lamotrigine that I'm sure many people have heard is the immediate risk of a skin rash, which can be detrimental and can be deadly. So within the first 7 days of administration of lamotrigine, you're either going to see it or you're not. And it looks like blotches in the skin. And if somebody gets this, they need to go off lamotrigine right away, because internally it just causes all kinds of problems and the person can die. So that's an extremely high risk with lamotrigine. However, the frequency is less than, I think, 0.04%. It's very small, but it happens, so it's important. across the board. Depakote is also very common, and blood monitoring is required. Depakote, I'm sure anyone who is in patient care or client care knows, most common side effect is weight gain, dry mouth, appetite goes up.
For me.
And but Depakote it's a good medication. It can be very sedating though, extremely sedating, and you're not going to see it paired for a boost with other things because it's a pretty heavy hitter. Then you look at lithium, who has been around forever, keeping in mind that the blood level monitoring is absolutely imperative for that, but lithium is a salt. So one consideration for someone on lithium is how much are they drinking, okay? Because with anything, any high salt diet, the more water you drink, the more salt you flush out, and lithium is a salt. So excessive water intake needs to be monitored. The other thing too that can come just a little bit off to the side, but still related, is people can actually get what's called water intoxication. And that somebody can appear psychotic. Floridly psychotic. And it can be, health-wise, it can be very dangerous. So with lithium, if someone is drinking excessively, that needs to be paid attention to, because they're going to wash the salt right out of their system, which is the basis for the lithium, because it is a salt. Okay. So Abilify, it's classified not only for mood stabilizing, but for antipsychotic as well. So it's often used to augment the lamotrigine. Sometimes it's used to augment other medications, or it's been known to be used by itself. But you'll probably see it. You'll probably see the two together. They're very commonly put together. So with the antipsychotic properties, you're probably going to see the Abilify more commonly with bipolar 1 than bipolar 2. With bipolar 2, lamotrigine often, just using that as an example, if you're looking for a mood stabilizer and a person is put on lamotrigine and it's effective for them for bipolar 2, that's probably all you need. One thing to keep in mind is that treating someone with bipolar disorder with an antidepressant will not work. Because what does an antidepressant do? It elevates mood. What happens when you're manic? It elevates your mood. So in bipolar 1 and also 2, but not to as big of a degree, antidepressant can throw somebody into a full manic episode. It absolutely can. So to give someone an antidepressant in combination with a mood stabilizer, you might see that with bipolar 2 a little bit, but you're not traditionally going to see it with bipolar 1. It's just too dangerous. So with bipolar 2, one consideration with regards to medication is that usually an antidepressant and a diagnosis of depression is going to come first in the record. If you look back in their history, you're going to see a diagnosis of major depression. And then you might see major depression with irritability. And then you may see major depression with borderline traits. Those three are very common in the record. And they're all inaccurate. When you get to the point of bipolar 2, chances are there's going to be quite a record established already for the person, because it's not a go-to diagnosis. You need to look over time, and you need to look at the level of disability and impairment and interference in functioning before you can make that diagnosis. So, questions thus far?
A question about medication.
Mm-hmm.
You were saying with lithium is just basically salt. I had a client on escitalopram.
Citalopram?
I think he had bipolar, so he was on that, but it made him.
Citalopram is an antidepressant.
Okay. Well, he was
Yeah.
on that, and I don't know, like, does that just make you thirsty, or like what makes
Lithium will make you,
excessive?
yeah, lithium will make you thirsty.
Because he
Um,
ended up in the hospital because he was drinking like gallons and gallons of water and just flushed out all his sodium, and so he was like delusional because of the
Yep.
low sodium.
And that was probably well on the way to water intoxication too.
Well, he was.
Yeah. Yeah, so there's quite a few medications that'll make you thirsty, but not because of salt, but because of dry mouth. And so citalopram, it would probably may have been that, you know, just the dry mouth, the dry throat. Medications like Depakote, lithium, citalopram, lamotrigine to some extent. A person's mouth can become so dry that they feel like they're gagging, like they can't swallow. It can be to that degree. And so to drink, it almost becomes a compulsion because they're afraid to choke or they're afraid to gag. And so that may be one consideration as well. So if say you've got somebody on lithium and you've got them on a medication that's going to cause dry mouth, you're going to have some problems. But often Cogentin, which is an old medication, Cogentin has some side effects of its own, but just talking about it for a minute, Cogentin can make a difference in as little as 4 hours. That's how fast acting it is. So if someone has, with an antipsychotic, say for example, or Depakote, you can get the joint stiffness, you can get the kind of cogwheeling, the click, 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 more commonly with antipsychotics. Cogentin can make a difference in as little as 4 hours. So clients have said, and people I've treated outpatient as well, have said, I took Cogentin for the first time when I went to bed, and I had a new lease on life when I woke up. I could get out of bed. I felt fluid. I could move my arms. I could reach my back to wash it, you know, things like that. So Cogentin gets a bad rap because it's so old and because it causes dry mouth to a large degree, but it is a fantastic medication for side effects. And often you'll see it with Cogentin, you'll see it with lithium, not as frequently with lamotrigine, but sometimes. So.
I think we have an episode, I think that Carla should mention, because we had a woman that's on our home care service. She was also at Berry House, but the effect of the Depakote, why don't you talk about that?
Well, she had the lithium. She had an overdose on lithium because it wasn't
It wasn't
going through her body. Right? It was staying wherever. And right now, she went to see the doctor, psychiatrist, and she ended up taking her off of Depakote because of the dry mouth. She could hardly swallow and stop her mouth. And she drinks not a lot of water, like Katie's, you know. But she drinks enough. But once she took her off Depakote, she's doing much better.
And the reason that that's interesting is because she would always complain at Berry House why she was inability to swallow. So we began to think, oh, she's just got some kind of crazy thought process going on here because she's saying this all the time and there's no reason. They've done all the tests. There's no reason.
Right.
Medication related.
There you go. And you bring up a good point about lithium. The blood monitoring is so important because when the body's not absorbing it and the blood levels get high, it's called lithium toxicity, and it can be deadly. It can kill someone. And so speaking of that, that's important. Yeah, I'm glad you brought that up.
She is getting tested now for dementia, too, because she's so forgetful. And she's going to Appleton for testing to see what her actual diagnosis is.
Okay. Have they tested her for UTI?
They did.
They did.
With
Okay.
That too.
Okay.
Yes.
So that's always one of the first tests that they do is for a UTI. The other thing is with forgetfulness and things like that, sometimes more frequent monitoring of the blood level, you know, will show not necessarily out of range, but fluctuation within the range, and that can cause some problems. So I'm glad they're going to look into it. It may or may not be a separate animal. Who knows?
Right. It could be all just what she's been through.
Right. Right.
Ever come back? The doctor said her.
Yeah. And her anxiety level.
Mostly short term, not, you know.
And anxiety is a great robber of memory. short-term memory. It's a great thief of short-term memory. And so there's so many factors that, can come into it, and you raise really, really good ones, really good ones.
Isn't lithium toxicity fairly common?
It's not,
Especially over time?
it used to be, the toxicity used to be more common, but it's better monitored now. What over time is the long-term side effects. If it's not monitored, then the toxicity is usually more of an issue. Side effects, longer-term side effects, the malignancy syndrome, things like that can occur on lithium too, and that's normally what you're going to see over time. As the system changes, the blood levels change. We all get older. We all, everything from our metabolism to our blood counts, it makes a difference. So the risk for toxicity that you were speaking to can increase based on chemistry, body chemistry as someone ages. So that's something to keep in mind. Generally, does it increase? Not that I've heard. I don't know. Perhaps, I don't know. But not that I've heard.
Okay. I have anxiety. I would say it's high at times. And there is something new out there that was just, I think it was FDA approved or whatever they call that. The patch. Is it a hemp patch?
Oh, the
Is it the
yeah.
CBD?
CBD or
CBD? Yeah, whatever it is, yeah.
I'm not a proponent of that.
Okay.
Because it just gives it's a magic fix. Looking for a magic fix instead of, and not speaking about you personally,
Right.
but it gives people the impression of a magic fix and I don't have to do the work.
You're going to have to be on this patch forever, if you want to keep.
They convince themselves that they are.
Right.
I don't think there's a doctor in the world that's going to say use one of those patches for the rest of your life. With anxiety, the best conqueror of anxiety is lifestyle change. Lifestyle change, not just in approach and interaction, but diet, movement, and it's scientifically proven. The research proves that lifestyle change decreases anxiety, increases potential for good memory, long-term and short-term, increases emotional stability, decreases sleep disturbance, decreases physical illness, improves social interactions, increases goal-directed activity, which all are disrupted by anxiety. And so combat one and address 1, address 10. And so the research out on that is just crazy valid, just crazy valid. So I would not. It's the magic of the hour. And I know there's some benefit to it with regards to pain, chronic pain for some people, so they say, but research has not been done to the extent where it's valid across the board. And so really, if we're honest about it, people see that and hemp as a form of marijuana.
Right.
That's what they see it as. So why wouldn't it work? Just because of the assumptions and the innuendos that are made with it. So I am personally not a proponent. So
what are your thoughts? Have you had any experience or anything with the float therapy that's just new?
Actually, I have. I've never done it, but I know a good handful of people who have done it. It's extremely meditative. The sound is purposely absent.
Yeah, they cut off all your senses.
Yeah.
Everything.
Yep. The salt water increases your buoyancy. So initially you might be a little anxious, but you're gonna be buoyant. The lights are low. However, I'm not a huge proponent of that either. In the moment, if you want to quell a high anxiety experience, beautiful. It's like doing a meditation. For some people, it's like doing an active yoga. However, you get up, you dry off, you walk out in the sunshine. You might hang on to it for a little while, but it's very expensive. It's very expensive. Pardon me?
It's not covered by insurance.
Oh, no. It's
But
purely,
I have a client who has severe PTSD and was a
Mhm.
prisoner of war and was in the Bosnian War and was been shot, and I mean, just has a real difficult time. And his therapist convinced him, kind of cajoled him into
To try
doing
it?
And he did, and I'll tell you, I haven't seen this guy that full of energy.
some
or
people
that-
really swear by it.
I said, Demir, what's your anxiety level at right now? And he said, 0. And this was the day after he floated.
And for some people rave about it, but there's just not enough.
You have to keep doing it?
Oh,
Or is
yes.
it one time?
Oh, no.
Yeah,
No, this is a chronic leisure activity that you're gonna pay for every time.
Is this like that was down in Milwaukee?
There's one in Appleton.
There's one, they have them in Sheboygan.
Right on
It's a
College
big thing.
Avenue.
Right now,
It is
it's
a big
supposed to
thing.
help with, more than just PTSD.
Pain, chronic
anxiety.
pain,
Yep.
yeah.
Because you're like floating around in the bath of Epsom salts, and then, so that's also.
And there are people
pulling
that
the
swear by it, but, I'm not gonna say it's good or bad,
Right.
but I know there's no research to support it, and it is.
And I was doing a little research, I was hoping we could get it paid for him, but, this was something that was done a long time ago as well, and now it seems like it's resurging.
It is researching,
And so
yeah.
you would think that they would have had a little more research on it when it was popular back in the day.
Well, you need to keep in mind that research stems from something that is considered a valid medical or psychiatric, psychotherapeutic treatment, okay? They're not gonna pay for research for a private business owner that's gonna open a salt-filled bathtub, put music on and lower the lights. It's considered actually a leisure activity, much like yoga. It's considered, a leisure coping skill, much like meditation or going to a sangha. Insurance isn't gonna pay for that either. And so you're just not gonna find that. Think about how long it took to get chiropractic care covered by insurance. Now think about chiropractic care and then think about floating. They just don't even feel the same. So to answer your question, the research, I'm not gonna say good or bad, some people swear by it. But again, I would utilize it to supplement the building of other skills, to support it, really. And then the frequency would go down, the cost would go down, So that's my 2 cents on that. Does that help?
Sure, I just trying
Okay.
to feel out people's
Yeah.
thoughts on it
Yeah.
because I seriously was amazed at the change in him the next day.
And
Like
part,
I said, I need you to do this paperwork. He's like, oh, all right, give me a pen. Like I can't get this guy to do freaking paperwork without getting irritable ever.
what's really beneficial is sometimes just the placebo effect of something. If you tell me it's gonna help, I'm that much more likely to think it's gonna help.
Right.
Whether it be the patch or floating or yoga or whatever the case may be, So there's a placebo effect in all that, especially the therapy of the hour. There's always a placebo effect to some degree. So, but you know what? Use it.
Well, yeah,
really.
He can't afford it, so that was his one and only float. And he is literally, and not because he's not floating, but he can't afford the therapy either. But he's just back to his grumpy old.
You know what?
Didn't last long.
You know what? That floating is a beautiful tool for a treatment plan. What was it about the floating that supported your mood being better, that supported you being more on task, that supported you engaging more? What was it about the floating? And put that in a treatment plan and bring it in another way, with other tools. Floating, yoga, meditation, lifestyle change, diet, they're all tools that you can incorporate in a treatment plan. In floating, you did it once, you've got all the tools you need right there.
Well, right, but as you say, all the other things that you mentioned, diet and yoga, requires work
Sure,
by the person.
but so does behavior change.
Floating requires you to just lay there. And
Right.
So,
Right.
you know, would I like to see him doing some meditation or some yoga?
Mhm.
But that requires him to go out and go to a class, or, I mean, I know
Yeah.
not with meditation, but
Right.
he's got to
And-
self-motivate.
And just as examples, but just using the floating and the skills and the tools acquired during floating, he can use those whether he's sitting in the bathroom or sitting in bed or sitting watching TV, whatever the case may be, those tools are available. And you don't have to buy them, go to them, nothing. So, because they were put in place the day he floated. So that's one thing to keep in mind. And then putting on him the fact that there were tools within this. So what are you going to do with them to help improve your experience or your... I could go on all day about that.
Well, interestingly enough, when you're talking about bipolar, what I always associate instantly with bipolar is addiction. You haven't talked about addiction and how they fit together.
I have not. Simply because, and I typically don't, but we can certainly go there. One thing to keep in mind is that drug and alcohol use, depending really what drugs you're using, but chronic use of different kinds can mimic a manic episode. And then if you have somebody who's depressed and they use drugs, it can aggravate the depression or it can lift them up. Okay, so the mood aggravates the use, aggravates the mood. Okay, someone who has untreated bipolar 1, much more likely to use drugs or alcohol because the person's subjective experience is uncomfortable. And if you think about being uncomfortable mentally, feeling pressure to talk, so you're uncomfortable physically, you're uncomfortable cognitively, what's the first thing that a lot of people go to? Marijuana. Absolutely, marijuana, because it's going to quell some of that. And it's interesting because in schizophrenia, the same thing applies. In bipolar disorder, the research from way back when, they tested tobacco use. Cigarette smoking helped quell symptoms of schizophrenia and bipolar disorder. But it wasn't because of so much the tobacco, it was because of the deep breathing, it was because of, the motion, it was because of the predictability in the structure, but drug and alcohol use, absolutely. That impulsive behavior with painful consequences, absolutely drugs and alcohol use are one of those categories. I just talked about like the sexual indiscretion and things like that, but it's not uncommon. I mean, it's pretty common, I would say. In bipolar disorder, alcohol use actually is less common than other drug use, like marijuana or benzos, because benzos will quiet things. Alcohol use, depending on access, environment, things like that. I mean, of course, alcohol is easy to get. It's very common. But for over longer term use, you're going to see other substances typically in there.
So, when I think of bipolar disorder, drug addiction is not the first thing that comes to my mind.
Really?
It's really not for me either.
Interesting.
I see it almost as I can see it as a precursor to, but I could see it as a symptom of as well. One thing to keep in mind is that the cognitive damage that you can do with certain street drugs can throw you into full manic episodes. And then somebody can be diagnosed incorrectly, and you put somebody on a mood stabilizer or you put somebody on an antidepressant, and they're going to become more symptomatic.
You see that so much more now with all of the drug addictions that people are having and different diagnosis from evaluation to evaluation to evaluation. Sometimes it's just like, because they're treating what they saw as a symptom of the drug.
Or they're treating what they saw as a symptom of an illness, and it was really secondary to the drug use. Yeah, and then the other thing too is secondary to medical conditions. When you speak of lithium toxicity, that's a medical condition. Or you look at memory loss, a medical condition, UTI medical condition. So you've got the drug and alcohol use, you've got the actual psychiatric illness, and then you've got medical considerations. And you can have a whole different picture in a second, just two people standing next to each other. So it's complicated. I mean, it really can be complicated. For someone utilizing support and clarity, bipolar 1 disorder, if someone is manic, the last thing you want to do is say, you need to calm down, because you've got that agitation piece normally in there. And then somebody's going to become upset. They're going to feel confronted. If they can't help it, if they're truly manic, they don't have a lot of control. So part of it is meeting the person where they are and seeing how you can help accommodate lessening the painful part of the experience. So sometimes it's just sitting with someone. Sometimes it's helping them call a family member. Sometimes it's going through their medication saying, did you take, not, I don't think you, but did you take? And creating some structure. On intake, wherever a client is, I think it's important to ask what helps when in this situation, what doesn't help, okay? If somebody comes in with a diagnosis of bipolar 1 disorder, the first two questions I'm going to ask is, what does it look like when you're experiencing a manic episode? Because you're going to look different than you are. The second thing I'm going to ask is, when you're in a manic episode, what helps? Do I come toward you? Do I stay at a distance? Do I communicate that I'm here to support you? Do I need to worry about your safety? Things like that, while keeping in mind there's rules and all that, But approaching people the same way just because they have the same diagnosis is not going to work. It's not going to work. Someone who is depressed, hypomanic, structure, support. I can tell someone that I'm available to support them and walk away. And that message, I'm available to support you, can make all the difference in the world. I don't have to hover. But still monitoring for dangerousness to self. Primarily dangerousness to self. With bipolar 2 disorder, you're not typically going to see any dangerousness to others.
Well, I think where it gets tricky for us is we see this person once a week or once every other week for half an hour. A lot of people with mental illness that have had it for a long time, they can hold themselves together.
You bet they
for 30
can.
minutes.
And that's the importance in trauma-informed care of the record and the specific criteria necessary in the record. So if I come in on a Wednesday, I can look back to the Tuesday before and those notes up to today, and I can establish a pattern. I can also more easily detect if that person is playing with me. But the documentation is crucial, and part of the difficult part is that the responsibility of the caregiver is to know and is to get that information,
And we're, like as a case manager that works with people out in the community, we don't have case notes we can look back on from last week. We don't have, we have our here and now when we're meeting with them, but aren't always aware, like a lot of my clients don't have any supports, in-home supports, med monitors, none of that. They're functioning on their own. So it becomes difficult to kind of get a feel for where they're at. Like I said, when you meet with them every other week for half an hour.
It takes more work, but they've got the psychiatrist. And the nurse that works with the psychiatrist is a beautiful tool. Can I talk to you for 5 minutes? Just to get a nutshell. That counts. That counts. Because, and trauma-informed care, that's the necessary thing, If I say I meet with them every other week and I don't have any other information, It's not going to work. That is not trauma-informed care. And so, like I said, it takes more energy and it takes more intention and intention. But there is a resource somewhere. You know, there's a note somewhere. It's not out of practice for someone in your situation that sees somebody every other week to request records from the provider every 3 months. That is not out of the question. And that's becoming more and more common.
Right.
You know.
Every 6 months, but.
Mm-hmm. And so that's something to think about too. Sometimes it's a phone call to the nurse, to the RN, you know, who is often a great go-to, even the medical assistant. So, but it makes things more complicated.
A bit.
Mm-hmm. But other questions?
I just have a comment. So I notice a lot of people with bipolar 1 will try to hide it, or like they'll stop their medications, you know, because they like that natural high. It's like, I would have to agree with Stacy where you said this is more of a natural high for them where they don't have to go and seek those drugs. But then they'll stop their meds and then they'll get manic, they won't see a problem with it, and getting these people into treatment then because they don't see that they have a problem
is very difficult.
It's very difficult, and like we can see it. And then, you know, you make the call to the hospital to see if you can get them hospitalized, but they're not suicidal. So a lot of the times they won't accept them because they're not suicidal. And so then you're stuck with this person in the community who doesn't see a problem and they're loving life because they're all sorts of manic and, you know, it makes them feel on top of the world, but they're so impulsive and it's just a matter of time before they get into trouble.
It is.
So that's the biggest frustration I've experienced with bipolar is because they just stop their meds. They love that feeling, and then we can't get them into treatment because they just don't see it as a problem.
And one other consideration with people with bipolar 1 stopping their meds, because that does happen very commonly, is that if you think about it, if I'm on Depakote and if I'm on lithium and I have a dry mouth and I've gained weight versus I can do XYZ all day long, absolutely. Sometimes it's not just about the high. It's about not feeling crappy. Because to someone who's manic, their symptoms being controlled feels like crap. And manic versus stable can feel tired, can feel depressed, can feel lethargic. And so that's something else to keep in mind too. It's not just the drive for the high. It's avoiding that too. And so that's worth a conversation with the person. You know, that's worth a conversation because sometimes medication adjustments or changes can make all the difference in the world. And if you can help coach the person into the same types of meaningful activity while they're on medications as a teaching tool, that can also make all the difference in the world. So does that help?
Yeah.
Okay. Other thoughts?
This conference will now be recorded.
Oh, we don't want that.